I'll be moderating this session along with Omer Trevisky and Jesse Sangilo. And we'd like to start with Seung-Young Yu, who's going to be talking on imaging-based prediction of geographic atrophy progression using ONFOS, OCT, and fundus autofluorescence.
And thank you for the opportunity to present at the angiogenesis meeting. And we evaluated the pre-atrophic lesions using AMD OCT and fundus autofluorescence. Today, I will focus on an imaging-based analysis of hypertransmission defect areas, with particular attention to their progression and lesion-specific functional changes. These are my disclosures. Persistent choroidal hypertransmission defects on AMD OCT have been reported as strong predictors of nascent and future geographic atrophy. Our previous study on eyes with early geographic atrophy has showed a strong correlation between GA lesion areas measured on fundus autofluorescence and AMD OCT images. Nevertheless, HTD-defined lesion areas were consistently larger than the corresponding hypoautofluorescence-defined areas. And this case illustrated that the hypertransmission defects can be detected on AMD OCT before the definite GA becomes visible on fundus autofluorescence. And these HTD positive but GA negative regions subsequently show atrophic changes, as suggesting that the hypertransmission may precede the fundus autofluorescence-defined atrophy. On this corresponding OCT image, the red box HTD area shows diffuse EG and RPE attenuation with an underlying hyporeflective band. So although this HTD does not yet meet the criteria for CROA, it already shows more advanced photoreceptor RPE damage compared with the hyperautofluorescence region without HTD in pink box. In this study, we performed a longitudinal imaging-based analysis with more than 3 years of follow-up to evaluate the prognostic significance of HTDs without GA for predicting the geographic atrophy progression. Swabsus OCT raster scans were used to visualize HTD areas. Fundus autofluorescence images were used to delineate geographic atrophy areas. HTDs without GA were quantified as the area difference between the total HTD area on ANFAS image and the corresponding hypoautofluorescence area. We evaluated whether the HTD without GA area predicts the future GA progression. As shown in this representative case, HTD and hypoautofluorescence area difference varied across years. At baseline, the HTD without GA area was the largest among the follow-up digits in this case, and GA enlargement during the first year was the greatest, despite the smallest GA area at that time. This pattern was consistently observed in the overall data set, and across 190 longitudinal image sets from 33 eyes, the HTD without GA showed a strong correlation with geographic atrophy growth in subsequent year independent of baseline GA area. Moving on. So far, I have focused on the structural characterization of HTDs without GA using ANFAS, OCT, and fundus autofluorescence. Based on these findings, we further assessed functional changes using microperimetry. Although microperimetry allows for comprehensive mapping of the entire macular region, the optimal implementation of microperimetry in geographic atrophy is not yet fully understood. In this part, we examine topographic structure-function relation by correlating microperimetry retinal sensitivity to multimodal imaging findings. We registered Maya microperimetry maps to fundus autofluorescence and structures and fast OCT-derived sub-RPE images. And then they compared the retinal sensitivity across different lesion types using the registered microperimetry points. As shown in this table, the retinal sensitivity was slightly but significantly reduced over SDDs and drusen by a mean of 1.4 decibel and more substantially reduced over HTD positive and then GA negative regions by approximately 6 decibel and with a mean retinal sensitivity of 10.5 decibel. Within established atrophy lesions, a retinal sensitivity showed a near complete loss. And here this table shows 3 months changes in a function. The best corrected visual acuity and overall retinal sensitivity remained stable, and whereas retinal sensitivity over the HTD without a GA showed a significant decline even within the 3 months. Among 128 points over the HTD without GA, the 8.5% progressed to scotoma within 4 months, so highlighting the limitations of global or perilesional microperimetry and the value of lesion-specific retinal sensitivity in GA follow-up. In summary, the difference between HTD and hypoautofluorescence areas representing hypertransmission without geographic atrophy may serve as an imaging biomarker for predicting the geographic atrophy progression and identifying when and where atrophy may accelerate and supporting the personalized monitoring and treatment. Longitudinal analysis demonstrated a larger macular sensitivity decline over HTD without GA area than in conventional perilesional regions. Multimodal assessment integrating both structural and functional parameters enables the detection of meaningful changes even over short time frames, supporting the comprehensive evaluation and management of geographic atrophy. Thank you for your kind attention.
Young, thank you for a beautiful presentation, fabulous analysis. And one of the things we always emphasize is on-fast imaging should always be evaluated combined with B scans. So I'm curious, when you look at these regions that are different between fundus autofluorescence and on-fast imaging, what do you see on the B scan? What's contributing to this increased hypertransmission that you're detecting?
So on the cross-sectional OCT image, we see the EG and ELM and also the RPE attenuation. And we see also the hyporeflective band under the RPE.
All right. I was also noticing in the B scan that you showed the choroid looked particularly thin in those areas. Was that a consistent finding or no?
Let me look at it. I didn't look at the choroid carefully, so let me look at it.
All right, Glenn, you're up.
Yeah, so this was probably a follow-up to your comment, Phil, but as you were talking, it was a very nice presentation. I was thinking how similar this was to the ellipsoid zone map prediction outside the area of the GA prediction of progression as well. And I was wondering if you had a chance to look at the two together to see whether one was more predictive or the other, or they're looking at the same thing.
Yeah, I haven't had a chance to use the AI assisted the easy measurement, so I would like to try with the AI measurement in the future.
That'll be an interesting comparison.
Agreed. Thank you, Seung Young. We're going to move on.
Thank
And
you.
Jimmy Chung's going to talk about incident atrophy and macular neovascularization in fellow eyes of neovascular AMD over 3 years.
Thank you for the opportunity to present these data regarding incident atrophy and MNV in the fellow eyes of neovascular AMD over a 3-year follow-up. Disclosures and acknowledgements. The risk to the second eye of patients presenting with neovascular AMD in the first eye is well recognized, both in terms of developing macular neovascularization and developing geographic atrophy. Previous studies reported up to 30% risk of MNV in the Caucasian populations and somewhat lower at up to 18% in Asian populations. Also, in terms of risk factors, the presence of non-exudative MNV at baseline, as well as the non-PCV subtype have been associated with increased risk. There are, however, few studies reporting the incidence of geographic atrophy in the fellow eye, particularly in Asian populations, and this is of great interest because we are also interested in the prevalence of GA generally, which has been recognized as being lower in the Asian population. Therefore, the aim and outcome measures of the current analysis is to determine the 3-year incidence and predictors of atrophy and MNV in the fellow eye of patients with unilateral neovascular AMD. The primary endpoint is incident rate of MNV or geographic atrophy over 3 years, and the definitions are shown here. Particular MNV is counted when it is active and exudative with the presence of SRF or IRF and confirmed on angiography. Whereas GA, we use the definition of C-RORA for GA, and we also looked at other milder forms of retinal atrophy. In addition, secondary endpoints included risk factors associated with incident events, as well as the subtype of MNV and the correlation between the first and second eye. The methods utilize the ongoing phenotyping Asian AMD cohort from the Singapore National Eye Center, which recruits all patients who present to us with neovascular AMD that is treatment naive. All patients undergo a standardized imaging protocol at baseline month 3, year 1, and continue to be followed up. The imaging protocol includes standard angiography, FAIC-GA, OCT, and OCT angiography, and comprehensive demographic and medical history are noted. For the current analysis, we utilize a 10-year study period between December 2015 and December 2025. Patients required to have minimum documented follow-up of 3 years with clinical information and OCT available, and the second eye needs to be eligible, as in there is no MNV and no atrophy at baseline to be eligible. These are the features of interest which are grouped according to demographics and medical history, ocular features, and finally imaging features which are based on OCT grading at baseline by majority, but some of the features are also confirmed by multimodal imaging. Here are the baseline characteristics. Out of over 500 potential patients, 252 met the inclusion-exclusion criteria. The characteristics included mean age of 70 years, male predominance, vast majority being Chinese and 70% being phakic. 41% reported current or past smoking. In terms of ocular feature, the baseline MNV subtype was predominantly PCV, and you can see the rest of the proportion listed there, with 4% presenting with type 3, which is quite characteristics of our Asian population. This is the primary endpoint. You can see that incident MNV was 30 eyes, representing 11.9%, and the survival curve is shown bottom left. In orange are the PCV subgroup, and the blue is a non-PCV subgroup. And so PCV subgroup in the first eye appear to have a lower rate of the development and MNV in the fellow eye. Moving on to incident geographic atrophy. This is pretty rare. We only had 3 eyes in the whole cohort, representing 1.2%. And again, the survival curves are shown bottom right. If we count additional milder types of ultraretinal atrophy, then the rate goes up to 4.4%. Here are some examples. This patient had type 1 neovascularization in the right eye at baseline, and the other eye at baseline had drusen and double layer sign. We followed up over 3 years, and you can see that the development of a patch of C-RORA in the left eye. Here is a different case with PCV peripapillary in the left eye, the first eye, and at baseline in the right eye, there was an area of perhaps iRORA. And over the follow-up period, you can see year 1, year 2, and now I'm going to show you the registered scans through year 2 to year 5. And you can see slow development of that patch of iRORA into clear C-RORA, and as well as expansion in the en-face image. Note that the choroid is relatively thick in these eyes, so some may call them a pachychoroid background. In terms of correlating the subtype of MNV between the first and second eye, here we see the diagnosis in the first eye on the left and by the y-axis, and the diagnosis in the fellow eye in the x-axis, and all 30 eyes are listed here. Let me walk you through. Patients who came in with PCV in the first eye, 6 of them developed PCV in the second eye, and 4 developed type 1, which is consistent with the theory that PCV probably develops slowly from a type 1 initially. Moving on to type 3, you can see that all 6 eyes that had type 3 in the first eye developed type 3 in the second eye, highly concurrent. Here are a couple of examples. Type 3 in the first eye, pseudodrusen and drusen in the left eye, also not such thin choroid. And you can see at 2 years development of type 3, very symmetrical appearance. Here is a case with PCV in the first eye in the right eye, and at baseline there's double layer sign, but no evidence of neovascularization, again thick choroid. Absence of flow signal on OCT and geography. Over year 1, year 2 follow-up was similar, and at 23 months developed neovascularization, and exudation and neovascularization was confirmed on the repeated FA. How about risk factors? Incident MNV risk factors are shown here. On the left are the demographics, and on the right are the baseline OCT features. Let me walk you through. Here are the associated with increased risk. We can see older age, type 3 MNV, any drusen, any PED, RP migration, and thinner choroid. PCV in the first eye and a normal OCT at baseline appear to be associated with reduced risk. Move on to incident atrophy. That shows you those features associated with increased risk. These include pseudophakia, RPD, stopped drusen, any PED, drusenoid PED, and RP migration. Note that the subtype of PED for the incident atrophy are somewhat different from that in the MNV. And again, if there is a normal OCT at baseline, this appears to be protected. So those were univariate analysis, and here are the forest plots showing you the age gender adjusted, highlighting the baseline OCT features are highly useful. So these are the summary. MNV developed in 12% and GA developed in 1.2% in the fellow eyes over 3 years.
Thank you, Jemmy. Beautiful presentation, fascinating data. But one thing that really caught my eye early on, your study has a male predominance, and almost every study of Western AMD has a female predominance. Why do you think there's a male predominance in your population?
Why, I'm not sure, maybe genetic, but it is actually many of the Asian cohorts particularly those coming out of Japan, have tended to report a male predominance. It seems to be also associated with PCV. In the past, the Japanese cohort particularly attributed to higher smoking in the males, but nowadays, when we look at smoking, certainly there is still more smokers in the males, but there are many males who are non-smoker who come in with neovascular AMD still in Asia.
Very good. Unfortunately, beautiful presentation, but we have to move on.
Thank
And
you.
Giselle Herrera is going to talk on measuring enlargement rates of large choroidal hypertransmission defects over a wide range of lesion sizes in AMD.
Good morning. On behalf of the OCT research team at Bascom Palmer Institute, I have the pleasure to present you today our most recent work on measuring the enlargement rates of large choroidal hypertransmission defects over a wide range of lesion sizes in AMD. These are my financial disclosures. But first, allow me to thank my wonderful team of researchers at Bascom Palmer, and also Dr. Wang's team at University of Washington, whose work has been instrumental in our research. Here are the important take-home messages. Fast OCT imaging is a useful strategy to follow the growth of hypertransmission defects. The area growth rate of atrophy is highly dependent on their baseline lesion sizes. For lesions smaller than 0.9 disc areas, the perimeter-adjusted growth rate eliminates the dependence on baseline lesion size. Although for lesions larger than 0.9 disc areas, the square root growth rate is the best option to follow the growth of macular atrophy. Disease progression in dry AMD was historically studied using color fundus imaging. But now, OCT imaging is the consensus modality to study the progression from drusen to geographic atrophy. Although multimodal imaging is widely used to study the growth of GA, we know that Fast OCT is particularly better than other imaging modalities like autofluorescence or color fundus to detect the smallest areas of atrophy, and especially those like, in this example, which are closer to the fovea. Fast imaging is built using dense OCT raster scans with segmentation boundaries that extend from 64 to 400 microns below Bruch's membrane, and that allows for the detection of the hypertransmission of light into the choroid in the areas where the RPE is missing or attenuated. We called these bright areas on the Fast RP images in the past persistent hypertransmission defects. They have a greater linear dimension of 250 microns and are confirmed with their corresponding B-scans. Years ago, we performed an exercise to find the smallest hypatides that will persist over 3 years, and we confirmed this 250 microns cutoff, which has been since reproduced and validated by other independent datasets. And we recently published a persistent rate of these lesions of 99.6%, although we decided to change the name from persistent to large hypatides. Now you might be asking, do hypatides predict the formation of GA? And the answer is yes, and here you can see our publication regarding this topic. But allow me to show you a beautiful example of the appearance and growth of hypertransmission defects into the formation of GA. Here, baseline visit shows an eye with only drusen and no hypertransmission defects that 18 months later develops the first hypatid. Later, as drusen volume collapses, more hypatids form and they start to merge and form larger areas of atrophy. But then the question becomes, what is the best strategy to measure the growth of these lesions? And to address that question, we need to revise a well-known dilemma, and that is that when using area in millimeters squared to follow the annual growth rate of GA, the growth rate continuously increases as the GA lesion size increases. And also the test-retest variability of measuring the area of GA changes as the lesion grows. This was addressed by Yehoshua and other authors by using the square root transformation of the enlargement rates, which significantly decreases the dependence of the growth on the baseline lesion size. A more recent approach was proposed by Liang using the perimeter-adjusted growth rate strategy, which controls not only for the baseline lesion size, but also for the circularity of the lesions and the multifocality. But we had some unanswered questions. Can these strategies be used on small lesions, starting with the size of a large hypophyty when they first appear? Do small lesions grow at a similar rate compared to large lesions? If so, what's the best growth rate strategy for measuring the growth from the onset of hypophytes to large GA? Is it the square root transformation strategy or maybe the perimeter adjusted strategy? And for that, we performed a retrospective review of a prospective OCT study at Bascom using eyes with untreated non-exudative AMD and at least one large hypophyte and 1 year follow-up. We reviewed both 6x6 and 12x12 web source OCT scans, and we ended up with 221 eyes from 157 patients. And here you can see the results. In this plot, the total area growth in millimeters squared without any transformation shows a high dependence on the baseline lesion size plotted in the x-axis. And this is for all lesion sizes. However, with the square root transformation, as well as with the perimeter adjusted, the dependence of the growth on the baseline lesion size decreases significantly. And we have decided to use the square root transformation also for the area in the x-axis to better distribute the data points and allow us to see the very clumped together smaller lesions. Which brings us to the next question. Do small lesions grow similar to larger lesions? So to answer this question, we statistically determined a breakpoint in our population of 2.25 millimeters square or 0.9 disc areas, which is very close to the most commonly used breakpoint in clinical trials of 1 disc area. And here you can see that for lesions smaller than 2.25 millimeters square or 1.5 millimeters, which is the square root of 2.25, the perimeter adjusted strategy performed best at decreasing the dependence on the baseline lesion size. This is likely due to lesions under this cutoff being more multifocal and less circular, characteristics that the perimeter adjusted controls for. On the contrary, for lesions that are larger than 2.25 millimeters square or 1.5 millimeter, the square root transformation performs the best at decreasing such dependence. So in summary, MFAS OCT imaging is a useful strategy to follow the growth of hypertransmission defects as they progress to form larger regions of atrophy. The area growth rate of atrophy is highly dependent on the baseline lesion sizes. For lesions smaller than 0.9 disc areas, the perimeter adjusted growth rate strategy eliminates the dependence on baseline lesion size. But for lesions larger than 0.9 disc areas, the square root growth strategy is the best option to follow the growth of macular atrophy. Thank you so much for your attention.
Thank you, Giselle, for a beautiful presentation. So let's say we want to treat earlier, smaller than 0.9 disc areas, which is pretty convenient since most current clinical trials start at 1 disc area. How would you enroll patients for these smaller lesion clinical trials?
That's a very good question. Thank you for that question, Dr. Rosenfeld. In fact, knowing this cutoff is very important for for clinical trials, and we need to be mindful, knowing that the dynamics of growth changes after passing that 0.9 disc area cutoff. It's important that whenever we enroll lesions that are smaller than this cutoff, if we project the growth over 1 year, 2 years, we know actually, and we calculated this an equation that allows to know what would be the growth for these type of lesions under this cutoff and above. And so we should always know that by the end of that year or 2 years, depending on the study, the lesion should remain smaller than 0.9. So we actually don't have to change the way that we measure the growth and follow these lesions.
Linus, question.
Yeah, thanks, Giselle, for this amazing presentation. I just have a quick question. So I'm just wondering if you have got a chance to do any power analysis using different growth rates in different subgroup cohorts in the data set. And I'm wondering if you have any thoughts on that.
Sorry, can you repeat the question?
So I'm just wondering if you have ever done any power analysis to see any growth rate metric or if any growth rate metric is better than the others.
We haven't done that analysis. So we basically just look at the growth. So we look at the correlations between these different growth methods, as you saw in the presentation, with these different populations. We actually did it first for all lesions, and then we divided because we realized that there was a disconnect, or the growth characteristics were different. But yeah, we haven't done that analysis that you suggested. I think we could follow up on that.
So, Linus, there was a piecewise statistical analysis that our biostatistician performed, and there was a clear break at 0.9 disc errors. Glenn, go. Last question.
Yeah, so this just gets at the enrolling these small lesions in clinical trials. One of the issues, as you get, aside from the fact that they don't grow as fast, which makes it very difficult to demonstrate an effect, and I think this is what happened in the Alexion study, where they probably would have had a positive result had they not included the small lesions. The measurement errors also are larger with the smaller lesions, so that's another issue when you're trying to enroll these small lesions.
Excellent points.
Interestingly, we are now looking at these populations, and we're focusing now on smaller lesions, and we're looking at fast-growing lesions within this population and slow-growing lesions. So I think in the future we'll be able to show what kind of like risk factors maybe we can look at to predict which lesions within these smaller populations are going to grow faster in a way that we can enroll these kind of patients and have these results that we want to get.
Yeah, that'd be helpful. Thanks.
Yeah.
And now let me introduce Linus Shen, the author of the Perimeter-Adjusted Growth Rate Strategy, which takes into account multifocality and non-circularity. Linus is going to talk about concordance and bilateral geographic atrophy morphology and growth rate endpoints in AREDS.
Hello everyone, my name is Linus Shen, a surgical retina fellow at Duke. I'm excited to present our work titled Concordance in Bilateral Geographic Atrophy, Morphology and Growth Rate Endpoints in AREDS. Here's my financial disclosure. Geographic atrophy is a late stage of atrophic AMD, affecting over 5 million people worldwide. The FDA has approved 2 intravitreal complement inhibitors with many other trials ongoing. The current primary endpoint in most GA trials is the total GA lesion area. However, the growth rate of the GA area varies widely among individuals, sometimes over 10 times, so the current phase 3 GA trials typically requires hundreds of patients followed over 2 years. One limitation of using the growth rate of GA area as endpoint is that it does not account for the various GA morphologies among individuals. Previous studies have reported that the growth rate of total GA area is higher in eyes with larger baseline GA size, non-circular GA, higher baseline number of lesions, and larger GA perimeter, potentially because those eyes have more at-risk RP cells near GA border. The Bascom-Palmer group, led by Dr. Phil Rosenfeld, previously proposed to use square root transformation to account for different baseline GA area. Although it's a major step forward, it still does not fully account for the shape, perimeter, and number of lesions. More recently, we demonstrated that the area growth rate is strongly associated with the lesion perimeter. Simply put, the larger the perimeter is, the more RP cells are at risk. Based on this, we propose a perimeter-adjusted growth rate. This metric unifies these morphological factors into a single measure, which we have shown can reduce the sample size requirement by about 54%. An alternative strategy for clinical trials is to use fellow eyes as the controls. Previous studies have reported moderate to high indirect correlation in baseline GA area and the GA area growth rate. But it's currently unclear if the fellow eyes of patients with bilateral GA have similarities in lesion morphology, topographic distribution, and square root transformed or perimeter adjusted growth rate. In addition, we don't know if and how much a fellow eye control trial will improve clinical trial efficiency. In this study, we first aimed to investigate the inter-eye correlation of GA morphology and topographic distributions. Next, we evaluated the inter-eye correlation of 3 GA growth rate metrics. Finally, we performed power analysis to estimate the required sample size for 1-year trial using fellow eye as controls compared to the standard randomized control trial. We obtained color fundal photographs from the age-related eye disease study. We identified patients with bilateral GA and manually delineated the border of GA lesions. We registered the GA contours in a coordinate system that allows us to analyze the morphology and topographic distribution of GA lesions. In this study, we analyzed a total of 226 eyes from 113 participants with bilateral GA, followed over 5.5 years. Here, I will show some examples of bilateral GA. The first patient has bilateral small central round GA lesions. The second participant has multifocal ring-shaped lesions with central sparing in both eyes. The third participant has oval-shaped GA lesions located infratemporally to the foveal center in both eyes. The last patient has kidney bean-shaped lesion located in the nasal macula, which also spares the foveal center. It is intriguing to see how similar the bilateral GA lesions can be, not just in size, but also in terms of both configuration and topographic distribution. We first performed an inter-eye correlation of baseline GA morphology characteristics. Fellow eyes demonstrated moderate correlations in total GA area, perimeter, and circularity index. Next, to evaluate topographic concordance, we generated heat maps displaying the frequency of GA lesions in the macula. Here, red represents areas of high frequency. The heat map illustrates a remarkably similar spatial distribution between the fellow eyes. We also calculated the GA area in each ETDR subfields shown on the set panels. We found a moderate inter-eye correlation in GA area in 4 quadrants. We next investigated baseline factors associated with each GA growth rate metric. GA area growth rate was confounded by all baseline shape factors, including the area, perimeter, lesion number, multifocal lesions, and circularity index. GA square root transformed area growth rate reduces the dependence on baseline GA area as previously reported, but it is still confounded by other baseline shape factors. In contrast, GA perimeter adjusted growth rate reduces the significant dependence on baseline factors. We investigated the inter-eye correlation of 3 GA growth rate metrics, including the GA area growth rate, square root transformed area growth rate, and perimeter adjusted growth rate. As we can see here, all 3 GA growth rate metrics showed moderate inter-eye correlation. But the GA area growth rate has slightly higher inter-eye correlation coefficients than the other 2 metrics. One possible reason for this trend is that the fellow eyes often share similar baseline characteristics. Since raw area growth rate is more dependent on these baseline factors, the correlation may be inflated. Another possible reason is that GA progression dynamics shifts as lesions enlarge. To investigate this, we analyzed inter-eye correlations within a large lesion cohort, where both eyes exceeded the baseline area threshold shown on the x-axis. Interestingly, we found that as the threshold reached 0.9 disc areas, the correlation coefficients for perimeter adjusted growth rate and standard area growth rate became comparable. To evaluate the practical utility of fellow eyes as clinical controls, we performed a power analysis for a 1-year GA trial by estimating the sample size requirement per arm. To detect 30% reduction in progression, we compared 2 trial designs, a standard and paired design representing a traditional randomized control trial and a paired design using fellow eyes as controls. We also compared 3 different growth rate endpoints. Here are the power analysis results. If a clinical trial uses GA area growth rate as the endpoint in a traditional randomized control trial design, we would need 250 eyes per arm. In comparison, a paired design would only require 149 eyes per arm, which is about 40% reduction. Using square root transformation or perimeter adjusted growth rate as the clinical trial endpoints will reduce the sample size requirement further. Here, a 1-year GA trial using perimeter adjusted growth rate in a paired design would only require 71 eyes per arm, which is 3.5-fold reduction. We next performed the power analysis based on baseline GA size using 0.09 disc area as a cutoff. If a trial only recruits small GA smaller than 0.9 disc area, the sample size requirement will be high no matter what endpoint we choose. In contrast, if a clinical trial with a paired design only recruits GA larger than 0.9 disc area, using the square root transformed growth rate as an endpoint would only require 72 eyes per arm, a 3.5-fold reduction. In addition, if the trial uses the perimeter adjusted growth rate as the endpoint, it would only require 50 eyes per arm. That is 5-fold reduction compared to a traditional randomized control trial using the area growth rate as the endpoint. In conclusion, we demonstrated that bilateral GA eyes showed moderate correlation in size, topography, morphology, and growth rates. Perimeter-adjusted growth rate effectively reduces the dependence of growth rates on baseline GA characteristics. Using fellow eyes as internal controls reduced required sample size by about 40% compared to unpaired design. A paired design with perimeter-adjusted growth rate in GA larger than 0.9 this area can optimize the sample size requirement and reduce the sample size by 80%, which is 50 pairs versus 250 eyes per arm. I would like to thank my collaborators and co-authors for this project. I would also like to thank the funding support. Thank you so much for your attention.
Dennis, that was a fabulous presentation. And now the take-home message that everyone wants to know. You've got a new therapy and you want to test it on small lesions. How would you design that clinical trial?
Yeah, thank you so much for the invitation as well as for the question. I think one issue for enrolling the small lesions is it's often hard to identify those in clinics. A lot of patients have very good visual acuity. They may be following optometry clinic. They may be asymptomatic. They may not even come to clinic. So I think enrollment could be an issue as well. And then the second part is the measurement. As Dr. Jeffrey mentioned, I also personally agree when I measure the lesions myself, it's highly variable to measure the lesion size because you have higher measurement error, the growth rate can be harder, so we probably need more accurate measurement by potentially using multimodal imaging, including OCT, hypertransmission defect, and maybe use fundus autofluorescence as a reference as well.
Very good. And what we're going to do is move on now, Linus. Thank you. And I'd like to introduce Sarah Pachiri, who's going to be talking on a similar topic, the symmetry of atrophy enlargement in AMD eyes with bilateral atrophy. Take it away, Sarah.
On behalf of the OCT research team at the Bascom-Palmer Eye Institute, I have the pleasure to present my work on the symmetry of atrophy enlargement in AMD eyes with bilateral atrophy. These are my financial disclosures. I would like to thank my Bascom-Palmer OCT research team and the University of Washington Department of Bioengineering. These are our take-home messages. In bilateral GA, 3 growth rate strategies were used to determine the symmetry of growth rates between eyes. These were the total area, square root area, and perimeter adjusted area. The strongest inter-eye concordance was seen in total area growth rate. Stratification by a baseline size of 0.9 disc area resulted in similar concordance across growth rates. The square root and perimeter adjusted strategies decreased the variability in growth rate measurements. Evidence of inter-eye concordance supports the feasibility of paired eye clinical trial design in AMD. Geographic atrophy is the late stage of dry AMD. Bilaterality of GA is reported in up to 77% of cases in literature. The question that follows is, can both eyes be used in a clinical trial? Well, it depends on the concordance between eyes. Published reports indicate an inter-eye concordance of GA growth rate of up to 0.88. Can we improve the growth rate variability between eyes? These previous reports of symmetry use the total area growth rate, which we know to have dependence on baseline area, focality, and circularity. The more recent square root growth rate developed by Hoshu et al. Controls for baseline area, whereas another method, perimeter adjusted growth rate by Shen et al. Controls for baseline area, focality, and circularity. More recently, and as you heard in one of the previous talks, Herrera et al. Found a size breakpoint of 0.9 disc area. For lesions below 0.9 disc area, the perimeter adjusted growth rate showed less dependence on baseline area. For lesions above 0.9 disc area, the square root growth rate showed less dependence on baseline area. GA imaging strategies used in these previous reports rely on color fundus imaging and fundus autofluorescence. However, studies have shown that color fundus imaging is limited in the detection of early and small atrophic lesions, whereas fundus autofluorescence cannot reliably distinguish the involvement of the foveal center. In contrast, we prefer on-fast OCT imaging, which is highly effective for small lesions and foveal involvement. Our dense raster scan technology takes 500 D-scans for each image. We then define the sub-RVE slab at 64 to 400 microns below the Brooks membrane. This shows the on-fast image of GA as bright due to choroidal hypertransmission defects where the RPE is lost or attenuated. This comparison study by Yahoshua et al. Showed good agreement between our on-fast imaging strategy and fundus autofluorescence for large lesions. Using this imaging strategy, we developed our data set from 128 fellow eyes of 64 patients with bilateral hyper-TDs. Their baseline area ranged from as low as 0.04 to above 17 millimeters squared. The average follow-up consisted of 41.4 months, and this provided 786 annualized intervals. The previous case we saw was a simple unifocal central GA. This is a great example of a complex case, demonstrating multifocality with many small hyper-TDs enlarging and merging over time. To explore inter-eye concordance, we analyzed the growth rates across intervals of all baseline sizes using the total area, the square root area, and perimeter adjusted area growth rates. We observed that the total area growth rate demonstrated strong inter-eye concordance. However, the square root area and perimeter adjusted area growths showed weaker concordance. Nevertheless, we can see that the data points appear more clustered along the line of unity for the square root area and perimeter adjusted area. This result was surprising because we expected better concordance for these latter two strategies, which take into account baseline features. On the next step, we used the breakpoint of 0.9 disc area and analyzed all growth intervals with baseline hyper-TDs below this threshold using the three growth strategies. Here we note that concordance is much lower for small lesions regardless of the growth strategy used. And again, the data point distribution is spread far from the line of unity in all three strategies. Here, we then plot all growth intervals with baseline hyper-TD above 0.9 disc area. We note that concordance is high and consistent for all growth strategies, but the data point distribution appears closely aligned to the line of unity, especially so for the square root area and perimeter adjusted area growths. In a second analysis, we assessed inter-eye agreement using Bland-Altman plots. On the top row, you can see plotted the agreement for lesions across all baseline sizes for the three growth strategies, whereas in the bottom row, you can see lesions only with baseline area below 0.9 disc areas. We observed that between the two categories, there is not much marked improvement in the bias and limits of agreement. We then stratified for baseline area above 0.9 disc area, and we note a reduction in the variability and the limits of agreement, especially so for the square root area and perimeter adjusted growth rates, matching the concordance results that we previously observed. In conclusion, in bilateral GA, three growth strategies were used to determine the symmetry of growth rates between eyes. These were the total area, the square root area, and perimeter adjusted area. The strongest inter-eye concordance was seen for total area growth rate. Stratification by baseline size of 0.9 disc areas resulted in similar concordance across growth rates. The square root and perimeter adjusted strategies decreased the variability in growth rate measurements. Evidence of inter-eye concordance can support the feasibility of paired eye clinical trial design in AMD. Thank you for your attention.
Sarah, thank you for a lovely presentation. So just so everyone understands what's going on here, the square root, the perimeter adjusted that Linus developed, showed lower concordance when we look at the entire population, despite the fact that square root controlled for baseline lesion size and perimeter adjusted for multifocality and non-circuit eye. Why is it that difference disappeared with the 0.9 for the lower lesions and were similar for the larger lesions. Why is the area that's less precise have similar concordance overall when we look at these data, even though there's fewer patients needed for clinical trials using square root and perimeter adjusted?
Thank you for the question, Dr. Rosenfeld. Indeed, we saw a higher concordance when plotting using the total area growth rate. This, however, shows that we can get a higher value in the numbers, also due to the reliance on baseline features, as Linus also mentioned. However, although the concordance was higher, there was a greater spread, there was a greater variation along the line of unity for the total area growth rate. Whereas the points were much more clustered for the perimeter adjusted and the square root area. And you can also see in the agreement analysis that the latter two categories that account for baseline features perform better than the total area growth rate.
Right, so concordance isn't the same thing as
agreement.
variability in the measurements, and that's where these other growth rate strategies give you an advantage in clinical trials.
Exactly.
Thank you, Sarah.
Thank you.
Okay, Roy Schwartz is going to talk on the structure-function paradox in geographic atrophy, limitations in best corrected visual acuity as a measure of progression. Take it away, Roy.
Hello, everyone, and thank you to the organizers for inviting me to give this talk. These are my disclosures. I'm medical advisor for Apellis Pharmaceuticals. Let's start with the problem. Why am I talking about this today? BCVA endpoints are commonly used in many GA trials, but how did we arrive at this point? BCVA-based efficacy endpoints originated from anti-VEGF trials for other conditions, such as neovascular AMD, DME, and retinal vein occlusion. This connection makes sense as structure and function are tightly linked in these diseases. This is shown in this case where a patient with wet AMD received 5 ranibizumab injections, which led to the resolution of subretinal fluid and an improvement in visual acuity. However, does what works in anti-VEGF trials actually translate to GA? The answer, as we will learn in this talk, is no. Let's begin with data from the CHROMA, SPECTRI, and PROXIMA A trials. This analysis examined two correlations. The first was between baseline GA area and BCVA change over time, assessed at various weeks from 24 to 96. The correlations at different time points range from minus 0.04 to minus 0.07, indicating essentially no correlation. They also investigated the correlation between GA growth rate and BCVA change, which was similarly weak, even at week 96. This indicates that neither baseline area nor growth rate correlates with BCVA change. In contrast to the strong correlation between treatment effect and visual outcomes seen in anti-VEGF trials, there is almost no correlation with GA. Here's another perspective on this analysis. In examining the sham observed arms of OAKS and DERBY, we found no statistically significant difference in the change of BCVA from baseline to month 24 between individuals with the slowest growing GA and those with the fastest growing GA. And so, if GA growth doesn't correlate with BCVA loss, why should we use BCVA as an endpoint? This lack of correlation was evident in our experiment where we asked 9 retina specialists, all with over 25 years of experience, to examine 49 multimodal images from the baseline of the OAKS and DERBY trials, as shown below. We requested their estimates on two aspects: whether the GA was subfoveal or non-subfoveal based on the reading center's definition of central 1 micron involvement, and their assessment of BCVA. They could choose from 4 categories of visual acuity listed here in descending order. Additionally, we wanted to know if AI could estimate visual acuity. To do this, we used an AI trained on the Phase 2 FILLY data by the Moorfields Reading Center for visual acuity estimation. Here you can see how the experts estimated the GA location along with the kappa scores for agreement. Overall, these scores were quite high. However, the situation is different for BCVA. It was much more challenging to accurately estimate BCVA based on GA morphology. Here are the numbers. The agreement for the GA location was substantial with a kappa score of 0.74. However, for visual acuity, it was only 0.31, which is considered fair. Unfortunately, although the AI performed better than humans, it still had only fair agreement with the actual BCVA. In summary, neither human expertise nor AI can reliably estimate visual acuity from GA imaging. And so if experts struggle to predict visual acuity from structure, this further indicates a lack of correlation between structure and visual acuity in GA. So far, I've demonstrated that visual acuity is poorly correlated with the area, morphology, and growth of GA. But why does BCVA fail in GA? There are several reasons. First, foveal sparing is a key factor. While this may seem obvious, it's important to remember that GA typically begins outside the fovea, allowing BCVA to remain normal during this period. A patient could participate in a clinical trial for 24 months while GA progresses dangerously close to the fovea, yet their BCVA may not change. In contrast, other measures, such as microperimetry, would show significant progression. It's all about location, location, location. Here is an example from two sham-observed eyes in the Derby trial. The first case began as non-subfoveal and grew by approximately 5.6 square millimeters. Ultimately, the GA did not involve the fovea, resulting in a visual acuity drop of 4 letters. The second case also started as non-subfoveal. The lesion grew similarly by about 5.6 square millimeters, but this time it involved the fovea, leading to a visual acuity loss of 16 letters in that eye. This illustrates that two eyes can exhibit identical growth, yet one can maintain vision while the other does not, making it impossible to distinguish true treatment effects from anatomical luck. I just mentioned that BCVA does not change when GA is non-subfoveal. However, even when GA is subfoveal, we can't always predict its trajectory. This is evident in a patient from the sham-observed arm of the OAKS trial. This patient began with more than 50 letters at baseline. Vision then declined, and if we consider the context of 2 consecutive visits showing a 15-letter vision loss, which is common in some clinical trials, we see that this patient indeed lost 15 letters over 2 visits. Fortunately, vision later recovered to baseline levels. The reason for this phenomena is preferred retinal locus adaptation, or PRL. PRL is the retinal area a patient uses for fixation when the fovea is compromised, as seen in subfoveal GA. Patients can learn to adapt by utilizing other areas of the macula, at least temporarily, until vision is fully lost. We can also observe this in another sham patient from OAKS using microperimetry. Microperimetry plots all fixation points shown here in blue and fits an ellipse around them. The cluster of fixation points and the fitted ellipse provide an estimate of the location of the PRL. Looking at this eye over time, we see that the GA area increases from baseline to month 24. However, the BCVA reflects this only partially, with an initial drop following by improvement. The PRL location aids our understanding as the patient adapted to an area outside the fovea. And so if BCVA is not a suitable outcome endpoint for GA, what are better options? Several alternatives are available, including microperimetry, QCSF, low luminance tests, OCTF, as we heard today, patient-reported outcomes, and composite endpoints. Ongoing studies such as MacuStar are currently investigating these endpoints. To summarize, we found that BCVA is inadequate as a primary or even key secondary endpoint in GA trials. Slowing GA growth does not directly translate to a BCVA preservation benefit due to the weak relationship. Additionally, concepts borrowed from anti-VEGF trials, such as the 15-letter loss, do not apply to GA. It's time to move beyond BCVA and focus on more relevant structure function endpoints in GA. Thank you for your attention.
Roy, very insightful, fascinating. So knowing what you know now about the regulatory authorities, particularly EMA, how would you change your clinical trial if you were to repeat it now?
Thanks a lot, Phil, both for the invitation and for the question. So, you know, these studies, most of these studies that for the approved drugs were designed nearly 10 years ago. And now we've learned a lot from OAKS. We learned from OAKS, from Chroma and Spectri. I think that today, what we know is that microperimetry and especially new targeted or defect mapping approaches, they have the strongest evidence base and the best structure function correlation. In that regard, by the way, OCTF also looks promising because it was trained on microperimetry data, but I know there were some reservations last session, and I think that a lot of learning is required. And also maybe contrast sensitivity via QCSF is most promising for early disease detection. And all of them go towards showing the effect on the patient's perception that the EMA is so much looking for.
So what would you do differently? And then Glenn's going to ask a question.
Yeah, so I think the points that Roy made are really important. And I think it may be that we ultimately can use visual acuity if we take into account the things that we're not taking into account now. So patients can adapt their their central fixation. Not all patients, and that's one part of it. The other is the geometry of the lesion, and you can have a subfoveal lesion, and somebody can eccentrically fixate as it grows until they fall off the cliff because they get beyond their fixation point. Or you can have lesions on either side of the foveal center, and they'll fall into the scotoma as they're looking across. And so we don't take those things into account when we're considering visual acuity, and perhaps with either AI or another approach to take into account the things we're not taking into account now, it may be possible in the future to use visual acuity, but we're definitely not there now.
So you would enroll non-foveal GA, a certain distance from the edge of the GA to the foveal center. What do you recommend?
Well, I'm going to actually address some of this in the talk that we're going to have next. So
perfect. So let me introduce Glenn Jaffe. Thank you, Roy. Correlation of foveal invasion with visual function at baseline in the Regeneron Sienna Geographic Atrophy C5 inhibitor trial. Take it away.
I'm very happy to be able to give this presentation on behalf of the Sienna investigators and on behalf of the Duke Reading Center. For those of you who are not as familiar with Sienna, it's a global multi-center randomized double-masked phase 3 study to test efficacy and safety of cemdisiran and pozelimab combination therapy or cemdisiran monotherapy compared to placebo. Eyes were enrolled with geographic atrophy secondary to AMD with a primary endpoint of the total GA lesion area growth rate, or the slope, in millimeters squared per year at week 52, and secondary endpoints were at least a 15-letter best corrected visual acuity loss, low contrast quantitative visual acuity, low luminance low contrast quantitative visual acuity, and a quantitative contrast sensitivity function. There were 2 screening visits, and this is important for the analysis that we did. These were 10 to 14 weeks apart, and we identified eligibility and also determined the estimated annualized geographic atrophy growth rate over that period of the 2 screening visits. The purpose of the study that I'm going to show to you is to determine the correlation between the foveal atrophic burden and the visual function at screening visits. And so this was really pre-randomization data. So again, these were participants that had geographic atrophy without macular nevascularization at screening visit 1 and screening visit 2. And we looked at the geographic atrophy lesion area, center point involvement, and foveal atrophic burden. And this has also been called the foveal invasion, or the percent of atrophy in the center 1 millimeter diameter central subfield on autofluorescence. And these were analyses that we did at the Duke Reading Center. In addition, the visual function was assessed, the best corrected visual acuity and the quantitative contrast sensitivity function. And an annualized GA lesion growth rate was determined using the geographic atrophy area at screening visit 1 and at screening visit 2. A Pearson correlation coefficient was used to determine the association between the foveal atrophic burden and visual function. We looked at the strength of the correlation, and that was categorized as weak, moderate, strong, or very strong. And you see on the right the ranges for the correlation coefficients, 0.1 to less than 0.4 for weak, going up to 0.9 to 1 for very strong correlations. For analyses by individual visits, we considered the screening visit 1 and screening visit 2 independently. This is an analysis of screening data from an ongoing trial. Sienna is still going on. And all of the results are based on the observed data, and they're descriptive. So this just shows how the patient flow went. There were a total of 324 patients that were imaged with geographic atrophy. And so both eyes were looked at, and so there were a total of 552 eyes with geographic atrophy, but without macular neovascularization. And then if you look at the eyes that had foveal center point involvement, 200, and 351 without. And remember, this is an ongoing trial, and so the eyes that didn't pass the screening visit 1 or who still are pending their screening visit 2 were not included in the analysis, and that accounted for 389. So that left a total of 163 eyes with geographic atrophy without neovascularization, 22 with foveal center point, and the remainder of the 163 were the ones without foveal center point involvement. And this is what we found. First of all, if we looked at the baseline demographics, these are really consistent with the previous studies. And if you look at the average age, it's about 78, 79 years old. Majority were women. Most of the patients were white. And so this is really very similar to what's been seen in previous trials. And that demographic distribution was quite similar at screening visit 1 and the group that were evaluated at screening visit 2. When we looked at the disease characteristics at the screening visit, you'll notice that, as you'd expect, those eyes with foveal center point involvement had worse visual acuity than the eyes that did not have foveal center point involvement, both at screening visit 1 and a similar proportion at screening visit 2. You'll also notice that the contrast sensitivity function, and this was only evaluated at screening visit 2, but was also worse in the eyes that had foveal center point involvement when compared to those that didn't. We looked at the annualized lesion growth rate by quartile, and this was actually determined over those first 2 visits, so we could get an annualized growth rate. And when you look at that, dividing them by quartiles, you'll notice that the eyes that had smaller geographic atrophy area at that first screening visit tended to grow more slowly when compared to the eyes that had a larger baseline geographic atrophy area. We looked at the correlation between the best corrected visual acuity and the foveal invasion, or the foveal atrophic burden. I'm using those terms synonymously. And you'll notice that overall, at screening visit 1 or screening visit 2, as you have a greater atrophic burden, the best corrected visual acuity decreases. And if you look at this, depending on whether it was with or without foveal center point involvement, you'll notice that the correlation was strongest, as you might expect, if there was foveal center point involvement. Similarly, we looked at the correlation between the quantitative contrast sensitivity function and the foveal atrophic burden at the second screening visit. And you'll notice that overall, there was a correlation between the percentage of atrophic burden, as you see on the x-axis, and the quantitative contrast sensitivity function on the y-axis. The correlation was strongest if there was foveal center point involvement, although it was still pretty notable even when there wasn't foveal center point involvement. To summarize the data then, the mean baseline annualized geographic atrophy growth rate, which was 2.4 millimeters squared per year, was consistent with previous reports. The fastest progressors, those in the 4th quartile, had the largest baseline geographic atrophy area on average. There was a correlation between the foveal atrophic burden and visual function as assessed by best corrected visual acuity and the quantitative contrast sensitivity function. The visual function correlations were stronger among those with center point involvement and those that had greater foveal atrophic burden. The baseline growth rate and the foveal geographic atrophy burden data are useful for clinical trial stratification and have been used in the Sienna study. And I think the baseline growth rate measured at 2 different points in your clinic and also that foveal geographic atrophy burden will be useful for your clinical trial decisions. Thank you very much.
Thank you, Glenn. Very provocative study. Now, how did you control for the fact that larger area lesions grow faster to begin with? Did you have some type of algorithm to adjust for lesion size?
So if you're asking if we've done either perimeter controlled or if we've been doing square root transformation on that initial growth rate, we haven't done it yet on the initial growth rate. But to me, it was actually interesting, just the mere fact that over a 3-month period that you can actually identify the growth rate. And we've seen that in the Ionis trial as well, that over a run-in period of a relatively short period of time, you can get a growth rate. And the people who are slow growers and the people that are fast growers tend to stay in their lanes. And we've learned that from the Gather 1 and 2 studies. And so I think that this idea of doing this short run-in period to help stratify the patients in the clinic and also the foveal invasion, which helps to correlate with visual acuity, together helps to balance out the groups and will allow more robust evaluation of the treatment effect. I think it's also going to be useful in the clinic. And I think the foveal invasion gets at that idea of why is it that we didn't have the correlation before. It's not just the center point involvement, it's how much of that central area is involved. And it doesn't even get at the geometry of the lesion, which is another level of analysis.
I think it's important, but due to time, I'm going to let Linus ask his question.
Okay.
Oh, thank you. Thanks so much for the interesting presentation and data. Some people would argue that if a patient has GA involving the foveal center, there's probably no point in treating them. But based on your data, it seems like even for patients with foveal center involvement, the foveal burden is still, foveal invasion is still associated with visual acuity. So would that support that we should still consider to slow down GA progression in patients with foveal center point involvement?
Yeah, I think that's a good point. I think if you have foveal center point involvement, but you have demonstrated very slow growth, then it still may be worth treating that patient because you definitely have something to say before they fall off the cliff. And that's what we need to get more information about to better characterize those people who might have gotten foveal involvement. And if those of you who try and recruit patients in a clinical trials, you recognize that's probably the majority of the patients have foveal center point involvement. And so I agree, that is an approach, and we need to get more information to predict exactly who's going to fall off the cliff.
Yeah, I'll just add my 2 cents here. Some of the most beneficial patients are the ones with foveal involvement. If you slow them down, they maintain that preferred retinal location outside the atrophy, and they're very successful in maintaining their visual acuity. But that's another talk coming up. Now we're going to move forward. David Lally is going to talk on controversy on ARED supplements in geographic atrophy.
Thank you to the organizing committee for the opportunity to share with you the controversy on ARED supplements in geographic atrophy. Here are my disclosures. As we all know from the landmark AREDS clinical trial, ARED supplementation reduced the risk of progression from intermediate dry AMD to the advanced stages of disease by 28% at 5 years. Advanced AMD was defined as the development of neovascular AMD or central geographic atrophy. In the follow-up AREDS 2 trial, adding lutein and zeaxanthine or omega-3 fatty acids to the AREDS formulation showed no additional benefit in reducing risk to advanced AMD and showed it was safe to swap out beta-carotene for lutein and zeaxanthine. Central geographic atrophy was defined in the ARED study by clinical features on color fundus photography located within 2 disc diameters of the foveal center. In eyes with category 3 or 4 AMD, ARED supplementation showed no treatment benefit in reducing the risk of developing central geographic atrophy. ARED supplementation also showed no treatment benefit in slowing the lesion area growth rate in this small post-hoc analysis of 68 eyes with minimal power. The addition of lutein and zeaxanthine in the AREDS2 study also did not show treatment benefit in reducing development of central GA. And in the following years, the general consensus was that AREDS had no treatment benefit for reducing the development or progression of geographic atrophy. However, there were data gaps with this consensus. For instance, incident GA is non-central at onset in 2/3 of cases, and GA progression into the central macula is substantially slower than into the peripheral macula. This is clinically relevant when thinking about the time taken for non-central GA to reach the foveal center, where it is usually accompanied by a significant drop in visual acuity. With this in mind, authors Keenan and colleagues evaluated lesion progression towards the fovea in the AREDS 1 and 2 datasets recently published in 2025. They selected eyes with GA measurements on color fundus photography at 2 or more study visits. In their proximity-based analysis, they analyzed growth of non-center point GA towards the foveal center. In the area-based analysis, they analyzed lesion area growth in both non-central and central lesions. They saw no treatment benefit of either AREDS or lutein and zeaxanthine on lesion area growth rate and no effect on vision loss. However, they did find benefit with AREDS in slowing lesion progression towards the foveal center, moving 35% slower than without antioxidants. And in the AREDS 2 analysis, the addition of lutein and zeaxanthine slowed lesion progression towards the fovea even better, moving 35% slower than AREDS alone. This treatment effect with lutein and zeaxanthine appeared additive to the original AREDS formulation. Limitations of this study included the use of color fundus photography and the exploratory nature of the study. Additionally, there was no data to compare the current AREDS 2 formulation versus placebo because all participants in the AREDS 2 study took the vitamin C and E doses used in the original AREDS formulation. Adherence to the supplements was also unclear. The potential to slow GA progression towards the fovea with AREDS was intriguing. The question now was, would this finding be replicated in other large data sets? And we have 2 good data sets to review. First is from Chroma and Spectri, which were the pivotal trials evaluating lampalizumab versus sham on GA growth progression in patients with bilateral GA. A post-hoc analysis was conducted to assess the effect of AREDS or other antioxidants and lutein supplements on GA progression. Lesion area and distance to the fovea were analyzed by fundus autofluorescence. The use of supplements was captured on case report forms, although this data was not captured uniformly throughout the study. This analysis found no treatment benefit from AREDS or lutein in either the sham arms or the pooled arms for slowing the lesion area growth rate at 96 weeks. And likewise, no treatment benefit in the sham or pooled arms in slowing lesion growth towards the foveal center. The second large data set we have comes from Oaks and Derby, which were the large pivotal trials evaluating pegcetacoplan versus sham for GA growth progression and included subfoveal and non-subfoveal lesions. 40% of subjects were taking AREDS at baseline with 93% adherence through the last study visit. A post-hoc analysis was conducted to assess the effect of AREDS on GA progression in untreated eyes that included study eyes from the sham arms as well as untreated non-study fellow eyes. Lesion area and distance to the fovea were analyzed by fundus autofluorescence. In the untreated eyes in Oaks and Derby, there was no treatment benefit from AREDS on the lesion area growth rate at 24 months. And this finding remained consistent when stratifying by lesion location at baseline, where there was no observed treatment benefit from AREDS in reducing the lesion area growth. Additionally, there was no treatment benefit from AREDS in slowing lesion growth towards the fovea. So why the conflicted findings between these studies? Well, despite them being large data sets, all of them were post-hoc analyses not powered to detect lesion growth rates towards the fovea. There were also differences in imaging modalities used to measure GA. The AREDS studies used color fundus photography, while the other 2 studies utilized fundus autofluorescence. and autofluorescence is more sensitive for detecting earlier atrophy development with perhaps less variability of the measurement. In addition, the visit schedule was more frequent with the lampalizumab and pegcetacoplan trials occurring every 4 to 8 weeks, permitting more data points in comparison to the annual visit schedule in the AREDS studies. In summary, multiple large datasets have found conflicting results in the effect of AREDS supplements on GA progression. These differences may be explained in part by differences in study populations, study duration, and the methodologies utilized to measure GA. The totality of data at this time does not support AREDS supplementation for slowing lesion area growth or growth towards the fovea, but certainly further investigation into potential benefits of AREDS in geographic atrophy is warranted. Thank you to the AREDS research group and the investigators from the Chromospectry and Oaks and Derby studies for their important work on this topic, and thank you for your attention.
Well, David, that's a very provocative study and probably wouldn't have even been done had the contrary study had not come out from the NIH. So reproducibility is important, and it's important to make data believable. So what's your current recommendation when it comes to AREDS 2?
Yeah, the current recommendation is patients with geographic atrophy, if it's bilateral, would be not to recommend it. These supplements, they also carry risks, and negative attributes for our patients. They can be expensive for our patients. They can upset their stomachs. There can be hard pills to take. So for the majority of the patients, I tell them, save your money, and save your wallet and just eat a healthy, balanced diet.
Well, you've just given me an idea for a debate that we have to have. I don't think we have an answer yet, but everyone's going to practice how they think is best. I would go around the panel and ask for their opinion, but we're already behind, so we're going to move forward. I want to thank you, David, and I'd like to thank our session 3 speakers and panelists and my co-moderators, Omer Travisky and Jesse Sangilo. Don't forget the virtual exhibits on the homepage, and if you haven't done so already, please take the pre-test, and then you'll get the post-test later tonight. Send your questions through the chat. It's on your home screen. Please participate. And a novel feature of angiogenesis is to reach out to individual attendees. So if there's anyone you want to talk to, go to your homepage and reach out and connect to an attendee. Now we're going to move on to a session 4 entitled Emerging Therapies for Non-Exudative AMD. Thank you all for your attention.